All right, well, my name's David Warnky. I'm a third year medical student. I did my first 2 years in Kansas City at KU, and I took the last year off and I was doing a Fulbright research scholarship in India, which is where this work is coming from. And now I am doing my third year and fourth year in Wichita, Kansas. So this project is called the Community Health Impasse. What can family medicine learn from the challenges, diversity, and worldview of primary healthcare in South India? So we can just jump right into it. Um, so basic background of this, basically my background was in social determinants of health, public health in undergrad. So meaning of this project comes from a lot of how can family medicine invest itself in the social determinants of health and the social things that impact life. So we know that overall life expectancy, this is actually from Thomas McCown's book, The Role of Medicine, has been more greatly impacted by improvements in living standards than by modern medicine. He talks about vaccines and antibiotics and things like that, but basically living standards have done more to improve health than a lot of even those things. There's a lot of evidence to suggest that primary care has been and will continue to be the best avenue, just because of how it's positioned in the community to address social determinants of health, at least from the healthcare perspective. And so this study particularly took me to South India to look at their different health systems, health structures, and see basically what are promoters to and barriers against working in social determinants of health from a family medicine and a primary care lens. Um, so we'll go from there. This is a brief map of the places that I was at and the different clinics I was at. We'll get to some definitions of these different clinics in a minute. But as you can see, the study was focused largely in South India, and mostly that's because that's where the contacts were, and we'll explain how that happened and throughout as well. But that's just a general overview of where I was at in this study in these cases. So this is a multiple case study conducted among various primary care settings in South India. So many of the authors who were staff and public health professionals at a organization called the Institute of Public Health in Bangalore, India, helped to select these based on their variety of care, and some like very gold standard social determinants of health, some just kind of your average family practice clinic in the city, and everything in between. So it was purposive sampling. The primary investigator myself then followed up with each clinic that was kind of suggested. I would send a message or call the clinic provider, and I would inform them of who I was, what the study was about, what I was hoping to do, and ask for their consent there. And if they consented, then I would go there and get an official formal consent. So cases were included if one, they provided primary care, if they spoke English, which was largely not a problem. Many of the physicians are educated, they study in English anyway, so that wasn't too much of a problem, and then were willing to participate. And so from November of 2019 to March of 2020 was going to be April or May, but lots of plans have changed, obviously. I visited various primary care clinics. I noted observations and conducted informal interviews with the people at the clinics. And so this is a little outline of how it went. You have some expert selection from the staff. Then I would make the initial contact via phone, text message, WhatsApp, whatever. And then I would go to the clinic, and I would obtain consent there and spend 2 to 3 to 5 hours just observing, looking at the facilities, just sitting in the waiting room, seeing what that looked like, seeing how staff interactions looked. And then I would get into informal interviews as the time allowed for the providers to be able to talk. So either over the lunch break, or they'd have a lull in patients and they'd come talk to me for a while. Those usually lasted 1 to 3 hours, depending on availability and interest in talking. I would take notes during the entirety of this time. And then at the end of the encounter, right after I went home, I would do a more formal journal entry as the impressions based on several different categories. So the clinics kind of break down into these, or the cases break down into these different categories. So you have solo practices, which are pretty unfamiliar here in the US, but this is one family medicine doctor or even just kind of generalist who has probably owned this for 20 or 30 years, but works out of his home and sees patients in every day, and kind of just a cash pay fee for service kind of thing. So 3 of those were enrolled in the study. Private clinics were more like our standard family medicine clinics here, where there's nursing staff, there's administrative staff, there's a few doctors, maybe even working there more than one. The PHCs, or the primary health centers, were government operated clinics. And so these are ones that the government funds either directly or through an NGO operation. And so this is kind of, they're set in each part of the city as the base level of healthcare for the population. The complementary systems were what we would call kind of naturopathy, but it's Ayurveda, so it's a very strong traditional feeling of health and healing, and actually had some really interesting approaches to social determinants as well. The not-for-profit systems were the best way I could call larger healthcare settings. They did some level of like secondary care, but did a lot of primary care, a lot of social determinants of health, but were largely funded by private donations or by fundraising or grant writing or something like that. And then the research institutes like the one I worked at, we're not exactly providing direct medicine care, but we're involved in quality improvement research among family practice clinics, or how to get care into rural areas, how to work on social determinants of health in those areas. So those are kind of how they broke down as far as the different sampling of the cases. So I just wanted to dive into the results. The like 5 major themes kind of arose as I was thinking what things promote and make it difficult to offer or to provide social determinants of health work in a family care setting or a family medicine setting. The first one, and probably the biggest one, is community responsibility. So the cases that were really invested in social determinants of health had a defined population, whether that's by socioeconomic status or by demographics, or even by like a caste or tribal kind of assignment. These clinics basically said, this is our population and this is who we're going to care for, and restricted care to them. And so it allowed for them to invest in whatever the local area was of need. So if farming initiatives were something that were going to be helpful because the large population were farmers in that area, that was something they could focus on. And so I think one contrast to here that I saw is that a lot of the patient panels can come from all over, and this was true of the private clinics there as well. It's harder to invest in the social things in that area, in that area, in that area, but if you can define the patient population, then it's much easier to do number 2, which is to work on social initiatives. And so some of the cool ones I saw were working on organic farming for farmers to make their work more profitable so that they wouldn't be outsourced to larger companies, working on higher education scholarships for people in the communities, just because we know that education elevates people's social status. So if you can continue to give people higher education, you can elevate that community's ability to earn income and not work such labor-intensive and migratory jobs. Food programs were there, lots of different social interventions that I saw, especially among 2 or 3 clinics that more than just providing medicine, as they define their population, they saw what other needs were going on, and they would work to invest their time, at least partly, in that as well. Another big theme that came out was this idea of long-term vision. And so one of the problems the PHCs have, even though they have this defined community and social interventions, they're often staffed by providers who aren't really invested in the area. It's a job and it's something that's going to kind of get them to the next step. But without the long-term vision, there's not that problem solving, and there's not that desire to see what the community really needs, because it's just kind of a next step thing. On the other hand, the 2 non-for-profits that were kind of the gold standard had been there 20, 30 years, had built trust with the community, which was a big issue when you talk about long-term vision. You need to have the trust of the community and understand what the needs of the community are. And even some of the solo practices, even though they weren't so like community-oriented and social determinants-oriented, had this long-term vision that kind of gave trust with the community and allowed them to invest in education and things in ways that other people may not have been able to do. And the 4th point would have been complexity management. So the basic difference here is that, like, I think I even went into this thinking you can establish some like top-down policy and then this is going to happen. But realizing that different communities are so various and so diverse, and so top-down policies are often ineffective in that. And so when you talk about complexity management, you talk about teaching and encouraging family care providers to kind of lead from the ground up and allowing the community members and your patients to be stakeholders in what is healthcare provision and what is social determinants of health work. And when those like kind of grassroots things happen, you can get to number 5, which is self-care. And so ultimately you want a community to take initiative for its own health. I can't think of anything more frustrating when it's like you want to give diabetes medication or something like that, and people, don't ultimately have that drive or have the education or whatever they need to kind of take care of themselves in a way. And so some of the cool things even here that I saw was one clinic actually even encouraging people to run for office and to reform their local government in a way that it could serve their health needs and serve them instead of kind of the corruption that was already going on. And so getting even into the point where like the community itself is functioning in a healthy way, and medical care will obviously always be needed. But if you can empower the community to kind of make healthy decisions and desire those things, then you can take a step back and allow the community to take care of itself. And so that was something that was totally new to me as well, something that I hadn't really realized or seen. But those are kind of the five big themes that emerged in working with a couple of the authors and people who are working at the Public Health Institute and the Academy of Family Physicians in India. Kind of came up with this little graphic, which sort of kind of envelopes all the things that were just discussed and what it looks like to offer what they call community-oriented primary care, which is this not new, it's like in the 40s that it came, this blend between public health and family medicine or primary care, and trying to really build a bridge between those two that seems to sometimes be lacking. And so this figure emerged from the themes and the discussions that happened from that. So I think big takeaway points from this is, I think for myself even, encouraging in education, in the medical education process, encouraging young students who desire family medicine or even don't desire family medicine to realize that it's a complex, challenging field, that this area of social determinants of health work can really go forward. And then also just kind of shifting our lens from like kind of here and now medical things to kind of going out into the community, and how can we orient our clinics in those ways. I know there are constraints here that are different than in India, that are different than everywhere else, but to start to problem solve those things, how can we build clinics that are going to be able to do that? And so I had a really incredible experience visiting these different clinics and seeing kind of the awesome parts of it and the harder parts of it, the parallels to the US and things that were totally different, and ultimately learned a lot. So thanks for listening, and thanks for your time.
Okay, David, I really like your presentation. Before I forget, could you tell me the name of the book that you mentioned at the very beginning, because I didn't catch all that?
It's called The Role of Medicine by Thomas McKeown, McKeown.
McKeown, okay.
Yeah.
It sounds fascinating.
It is. Several books were recommended by the local professionals there, and that was one of them that was really kind of eye-opening.
Yeah, okay. So you mentioned, I think, that you thought the not-for-profits seemed to have maybe a more robust inclusion of social determinants of health.
On the whole, yeah. And I'm doing deeper analysis of this stuff right now with the other authors of the paper, and trying to work out like what to say about what that means for funding structures and things like that. Because there are challenges to not-for-profit. I mean, you have to continually fundraise, and programs definitely had to be cut at times because funding wasn't there. But when you have the blanket funding that's kind of coming regardless of what services you provide, it seemed to provide more freedom to invest in those community efforts than some of the other ones.
And that funding was not coming from government sources. It was
so the non-for-profits were not government, with the exception of like grants. Every once in a while, one of them did write grants, but the other one did not write any grants. It actually didn't want government involvement. So
okay, did those clinics employ things like social workers, pharmacists, community activists? I mean, what?
Yeah, so
They had them in the clinic?
The first level is community health workers. So they don't often report to the clinic. They kind of live in, they're really villages, but small towns, and will come report information once a week to the main clinic. But they're like, following up on appointments to make sure people are getting their meds. They're screening maternal fetal care stuff. So they're like doing the base level kind of screening stuff. And then there's a kind of a bridge person. It was a little different each place, but this is kind of the general outline. There was a sort of pseudo-social worker who would oversee several community health workers. And so bigger problems would be worked up there. Social issues would be worked out with finances or not being able to afford food or whatever it was, would kind of get screened there. So they kind of had the community health workers and then the social workers. And then at the clinic itself, there were like nurses and physicians, varying one to several physicians. And if like someone really needed to come in, if they, said we're hypertensive, problematic hypertensive pregnant women would come into the clinic and then they'd go from there, or if they're having trouble with medication or something. But the big things that were really happening in the community that like expanded the reach of the physician were those community health workers. There were problems, especially with the government community health workers, but the model itself was really interesting.
I think that kind of model's been used throughout the world, and very successfully. A lot of it may be that trust issue of these are people who live in our community and we know them and we see them.
Mm-hmm.
Sort of like the rural physician might be in Kansas.
Mm-hmm. Yeah, it's true. Yeah.
Let's see. Of those 5 major themes, the elements, which did you feel was most important?
I would say the community responsibility. It's also the hardest to actually like implement, it seems, unless you have outside funding. But definitely like identifying a community, especially like if there's some demographic component. There can also be cultural components where the community is like culturally related, but demographically helps you invest in the school system there. It helps you invest in like grocery, like here practically grocery stores, but like what food's available, and you don't lose kind of that diaspora. So if you can define your community, it gives you just kind of a laser vision for what social interventions could look like.
Okay, I guess you did kind of mention that. So it seems that being able to get that funding, not just from medical sources. I mean, when we say, well, we're going to fund Medicaid or Medicare, that goes only to the healthcare services, and you can't use it on all of these other things. So we've got to think about other funding sources.
Yeah.
So I think as time has gone by the last couple of decades, and we've slowly come to realize how important social determinants of health are for our patients, I'm left kind of wondering how can we implement this or these sorts of things in the U.S. or in Kansas particularly. I know, and I'm retired now, but as a physician, I could be aware of it, and yet I had such limited knowledge and availability of what's in the community or what we need in the community. So what are your thoughts on that?
Yeah, this is something I am continuing to grapple with, and even in my career, trying to decide what's the best avenue. I think more and more, especially in third years, I see the time constraints of physicians. It seems like part of it has to be a little bit extracurricular, whether that's getting research funding to like allow for some of that work, or so like on that perspective, maybe some like split time between like actual clinic and social determinants that somehow is funded, from grants or from private funding or something. But the other thing I think from a personal level is for me to actually invest in a community. So whatever my patient population is, and figuring out how to restrict that, living there. That way my neighbors and I can know what's going on there, whether that's in Wichita and going to a, lower income area, if that's the population I want to serve or whatever it is. So making that decision, because that was a large driving factor even there is like a physician making the choice to go somewhere to be invested in that community. We see it here in rural Kansas too, like someone who's going to actually go there and be invested and say, you know, this is what I'm going to do. And so then the question becomes, how do you motivate people like that? Because they're few and far between. And so part of that, I think, even comes in health education and allowing greater exposure to what that looks like. I know KU does a really good job of trying to expose people to rural medicine or to like family medicine that's kind of problem solving in those kinds of ways, but even vamping up education in those ways to expose people like myself to this idea that, hey, you can really make a difference in a community, not just like with your medical care, but with your role as a trusted physician, as a trusted friend, as a neighbor, on school boards, whatever that looks like. It might not always be all in the clinic, but there's places to do that. And so then it comes to like motivating those people to do that, which can be really hard. This is not an easy problem, and I'm wrestling with it a lot, but those are some of my biggest impressions.
Yeah, this is not an easy problem. And I do think our rural physicians probably have a leg up on the more urban physicians because they are known in the community and involved in other activities.
And they sort of have that defined community in general anyway, because it's small enough that it's like, this is the community you would serve anyway. So they kind of have that going.
I think your point of this needs to be a part of medical education from the very beginning. And I would argue not just for people heading into primary care, but all physicians need to be aware of this, because it does no good for an orthopedic doctor to just say, well, go do this, and ignore their ability to follow the directions and advice. Yeah,
Definitely.
So do you intend to do any further research of this in the US and look at various models of clinics and how they're implementing some of this?
I hope to. Right now it's restricted to reading of different models. I'm really interested in reading about actually Europe right now, because you just hear a lot about like, oh, their kind of oversight structure is really good and whatnot. I'm in there. So right now it's like kind of just reading about our healthcare system, reading about good models, reading about things that are broken. I'm hoping to continue to invest myself in more, social determinants of health research in the future, but I'm also just plugging into third year right now and trying to get my feet under me for that. So
it's sort of hard to do all these other things, isn't it?
It's a little bit,
learn medicine,
Doing the best we can.
I can tell you that as you practice, this becomes more and more, at least it was for me, more and more aware of the limitations of how we're practicing. I have really enjoyed reading Paul Farmer's books. I don't know if you're familiar with that. And
I know who he is, but I haven't read anything.
Oh, you're missing out on a good resource and some ideas on how he has treated people in Haiti and Venezuela and Russia and stuff like that.
I think Michael Marmot, I don't know if you've heard that name, is also a big name in this category from Europe. So a lot of Indian resources end up back to like England. But Michael Marmot's a big name in the like kind of public health, social determinants of health groups over there as well. So I'll have to add to my reading as well.
Okay. Well, I applaud you for your interest in this, because I think it's the coming issue for providing health care in the U.S.
Thanks.
Another thing, you mentioned the self-care of a community, and mentioned the support of one person who was politically trying to become more active to help change the community. What do you think a physician or a clinic's role in that should be?
It's hard, especially in our current political context. It gets so polarized. I actually went in several meetings with physicians in India talking about this very thing, like what's our role? Because there are different views on things, and people who can want, a thriving community and think there are totally different ways to go about it. But I think the big step is local government. And in this case specifically, it was like an issue of corruption, and the community was just losing out on a lot of government funding that was available to them. But even though it was obvious there, I don't think it's like absent here as well. And so encouraging, stand-up quality people who are invested in the community to run and empower them to represent their community, I think is probably the best. Like, that's what I saw done and seemed the most appropriate, is just knowing who is like kind of, I don't know how to say this well, but like of a pure heart and integrity and just desires the best for the community, and encouraging those people to kind of take leadership in their community, and even in the small government kind of way.
Yeah.
That's the best answer I have for that.
Okay. All righty. Well, those were the questions that I was thinking about. So I don't know, you may get some questions when people see this video.
Maybe.
And, I would sure love to hear feedback of others if they have that opportunity to make it.
Yeah, definitely.
Physicians in different types of clinics here in Kansas.
Definitely.
Yeah. Well, again, I hope you get the opportunity to do more of this research.
Yeah, thank you. Me too.
It's obviously very passionate for you.
Yeah. It's something I care deeply about. So.
Okay.
Yes, it's very evident in the research that you presented and the passion that was behind all of your words that you just spoke. So thank you so much, David, for your presentation today. And thank you so much, Dr. Coates, for being our moderator.
Yeah.
Okay. All right. Thanks for the opportunity.